Good morning. I'm Dr. Michelle Nixon, and hopefully you guys can hear me. Trying to see where to bring up the presentation, and I'm not seeing it on my screen.
At the bottom of the screen, there should be a green button that says Share Screen.
Yeah, I've got the share screen up, but it's not showing my screen.
Let me see. I'm going to make you a co-host for the meeting and see if that allows you to share your screen.
Okay, and then Shiloe should be a co-host as well.
And while we're getting that set up, I'll do some introductions, I guess. So Dr. Nixon and I both work at the Trauma Awareness and Treatment Center in Salt Lake City, Utah. And we specialize, as the name denotes, in trauma, but we see cases of varying kinds, varying different diagnoses. But what we see undergirding a lot of those different diagnoses and cases is trauma. So Dr. Nixon's been doing this work for years. I'm going to leave her introduction to her, but I'm an intern at the Chicago School, from the Chicago School, and I've been studying this particular method that we will be talking about today under Dr. Nixon's tutelage, as well as our site director, Dr. Neal, who developed a particular modality of it.
So Shiloh, it's not allowing me to share that part of my screen. Can you, by chance, pull up the slides and see if you can get them on your screen?
Sure, yeah, I'll give that a try. All right. Let's see here.
Is that me or you? Oh, that's me. Okay, I've got it.
All right.
See them on your screen then?
I've got it. We're good.
All right, awesome. If you guys have any problems with this, let me know. Shiloh, go ahead and finish your introduction.
Actually, I was going to pass it off to you just to do your background a little bit, and then we can get started.
Okay, awesome. So my name is Dr. Michelle Nixon, and I'm actually a trauma therapist and have been doing that for years. I work with the Trauma Awareness and Treatment Center. My doctorate is in counseling, education, and supervision, and my dissertation was done on the method that we're going to introduce for you today. So we're going to talk a little bit about ego state therapy and how to utilize process-guided imagery in ego state therapy. And because of sort of the limitations we have on time, we're going to go pretty quickly. So anything that you need to follow up with us on, please email us and we will get back to you to the best of our ability.
And it's looking like we have a few people that are saying they still can't see the slides. Is that still the case? Okay, yes, we still have people who can't see them, who cannot see the slides.
So you can see it, but other people can't?
Let me see.
Let me just go down to.
How's this? I'm going to share this. Can everybody see that?
Yes, thank you.
Okay, yes, they can see it now. So Michelle, I'll go ahead and just just let me know when to advance the slides.
Okay, so are you going to go ahead and start with the definitions?
Mm-hmm. The view didn't change for anybody, did it?
Nope.
Okay,
just
good. Good. All right, so we're going to dig into the definitions. With ego state therapy, one of the things we notice is that in counselor education, it's not well represented across the board unless you're in a program that emphasizes that specifically. And so it's important to get a feel for some of the prominent lingo that may be tossed around, things that may be familiar to some of you and unfamiliar to others. Because of time, we do want to go through this rather quickly. So I've made these slides available to Dr. Hudson as well, for those of you who want to have a closer look at, a granular look at the definitions. But some things that stand out that we really will be talking a lot about today is the differences between bottom-up and top-down processing and bottom-up and top-down treatment. What we essentially are referring to when we use bottom up versus top down is we're approaching treatment and processing from the physiological up into the cognitive. And, if you can imagine the body with the nervous system, we're starting with the extremities, essentially viscera and all that way, all the way up into your frontal cortex. So processing trauma, that's the big point here, is that this approach specifically facilitates bottom-up processing. And then as you'll see down here as well, some terms such as the cabin or safe place or dissociative table. That's something that specifically gets used in this modality that we're going to be talking about. It's essentially a place where we can start interacting with parts of personality in a safe and constructive way. And then we have ego state. What is an ego state? Well, an ego state is, for in the interest of time, is a part of personality, part of self. And it develops to respond to the needs that are presented to us by our environment and by the people around us. Now, ego state therapy, well, taking from the previous definition, basically is a designed to address those parts directly and to facilitate communication between the parts and some sense of community, internal community. And then we have higher self, which is oftentimes tagged to a center self or an executive self. Some of you might be familiar with that terminology. And then the inner child is another ego state. Now, imprinting is something that I haven't seen elsewhere, but I've seen it in Dr. Nixon's dissertation. And basically, I wanted to just read that in full. It's the biophysiological association of trauma to the reactionary stance of the victim, contributing to a fundamental reorganization of the way mind and brain manage perceptions. It changes not only how we think and what we think about, but also our very capacity to think. So essentially, imprinting is those changes from a holistic perspective, a global perspective of the person. That's how trauma changes their lives. It's that imprint that it has physiologically, spiritually, cognitively. And then post-traumatic stress disorder, we've defined that somewhat here in a general sense, but we wanted to put that out there because we are going to differentiate between PTSD and trauma in general. And that's important because so much of what we will talk about is the evolution of traumatology and how that evolution has been beneficial for the field, but also created some challenges. And one of those things is identifying things that are sub-threshold PTSD criteria-wise and still being able to address the pain from trauma. And then we have the rapid pain release, which is the specific modality we will be addressing today. Top-down processing is opposite of what I talked about. We address the cognitive frameworks first and then get down to the body. We're addressing thoughts and going down to the viscera. And then I'm going to hand it off to Dr. Nixon to talk about trauma versus trauma disorder and in just a moment. And I just wanted to point out one more, that last definition there. Evaded ego state is that part of self that is flaring essentially and creating, it's drawing a lot of attention to itself and it's highly reactive because of the trauma and the impact on actual neurology. Okay.
So just to clarify a couple of concepts a little bit different, we also call ego states subpersonalities. So I don't want to confuse that with the ideology of Freudian literature that says the id, the ego, and the superego. What we're talking about is subpersonalities or parts of self. And so if you think about it, we're all wired with a certain set of characteristics that we call temperament. And then from our experiences, we begin to develop what we call ego states or subpersonalities. And so really what we're looking at as a framework that defines the biological nature of who we are, which is temperament, and then how our experiences create who we are in our environment. So those would be the ego states or subpersonalities. And that would be differentiated from the they are subconscious processes, but that would be differentiated a little bit from what the Freudian literature would indicate. So just to clarify that, and if you have further questions, just get that to us on the chat, and we'll go from there. And then we want to give you just a little bit further clarification on what we mean by trauma. So one of the impacts of trauma is really well defined by van der Kolk when he says trauma results in a fundamental, real organization of the way the mind and body manage perceptions. It's changed not only how we think and what we think, but also our very capacity to think. And that's one of the reasons why it's very important for us to differentiate between those bottom-up processes and the top-down processes. Top-down processes are generally considered cognitive in nature and would be defined as things that would be utilized in strategies like narrative therapy, cognitive behavioral therapy, and such. And what we're looking at is really more those bottom-up processes. So just to give you a definition of how we're considering trauma, and you can see this in my dissertation, we talked about trauma being when your internal resources are insufficient to deal with an external stimuli. And we wanted to narrow that down to a simpler understanding, because what seems traumatic for me may not be traumatic for you at all. And so when we're defining trauma, we can still do interventions that will allow the release of those body memories, the release of the pain associated with trauma, and allowing you to move forward. But it may be sub-threshold to what we would consider PTSD. This intervention does work sufficiently with PTSD, but it's there's other levels that we would work with in order to define ways to deal with and manage PTSD specifically. So the technique that we're introducing is really about dealing with trauma and giving you the capacity to minimize the amount of reactivity so that you can move on with behavioral strategies that are more effective. Do you want to move the slide forward?
Are you seeing that? Moved it to the biology of trauma.
Sorry, we're really new to this back and forth thing, so we're going to do the best we can. So we want to talk about the reactivity of trauma, and basically we have different parts of our brain, and when we're talking about the reactivity from trauma, we're talking about the midbrain or the limbic system. So basically we have the hindbrain, which is the cerebellum. It manages all of your autonomic responses. Then we have the midbrain, where a lot of the core structures of the brain are, including the amygdala, the hippocampus. That's the part of your brain that will actually help to organize memory. It's the part of your brain that's responsible for the fight, flight, freeze mechanisms. It's a part of your brain that's going to release the chemicals that get you ready to do anything that's life-preserving or life-threatening, to manage those kind of stimuli. So when we're looking at the bottom-up processing, what we're really doing is looking at how do we navigate into that limbic brain, and what sort of techniques are going to minimize the amount of reactivity that we see there. Also on this slide, you'll see how the amygdala may assess a threat and then activate the polyvagal vagal system, or the dorsal vagus. And that's interesting because that is an area of nerves that actually go to the gut. It tells the gut to shut down. It goes to the heart, tells the heart to speed up, tells the breath to get more shallow, and then causes the activation of the cortisol system within the kidneys or the adrenals. And so when the amygdala assesses that threat, it's going to send the chemicals out very quickly to get you into reactivity. And our goal is to settle that down. That's one of the reasons why we talk about a lot of trauma memories being stored in the body, has to do with the activation of this system, because it's also within the system that the structure of memory will begin.
Okay, so what do we do with trauma? How do we address it? Well, I was going to insert a graphic here on this slide that basically just shows the alphabet, because we're throwing the alphabet soup at it. All these different modalities, we're trying all sorts of different things with varying levels of success and challenges. Now, I want to be clear as we embark on this segment of the presentation that this is not, this is in recognition of all of the research that's been done on these modalities and these approaches, as well as saying, you know, what we're offering here, what we're talking about here has a place among these things. And the research shows that at the very least, it's just as effective as the ones presented here. And if not, in some ways more for specific cases. Now, I don't need to read through the list. You can see it there. This is a lot of what we've thrown at it. And we want to talk about some of the challenges that we see. Now, I referenced earlier that the evolution of traumatology has created specific challenges to challenges and opportunities. But one of the things is that this evolved from initially from studying men and warriors and soldiers, you know, and then they started seeing how it was these same kind of suite of symptoms were showing up in people who had no combat experience, who had nothing to do with warfare, and even down into children. And so as we go along, which the goalposts kind of keep moving on us, but we're doing the best we can to identify, well, what does trauma actually look like? What does treating it actually look like? What's successful? What's effective? And so the other thing that I wanted to address was making it, kind of bringing this more anchoring into experience. Some of us have sat across from the client who has been silent in the session, who clearly doesn't want to be there, who is curled up and twisted up, and they don't want to offer anything to the process. And sometimes those clients get labeled as difficult or resistant. And at times, this is where the diagnostic definition of trauma can fail us. Because even if diagnostically someone's, you know, coming in with anxiety or depression, that may not account completely for their resistance in therapy. And if we miss the trauma, we overlook effective treatment. And so that's one of the challenges with trauma. And the other part of it is that the effect that trauma has on the brain, that cognitive dampening that you saw, makes it difficult or impossible for clients to speak about what's bothering them. They just know that, you know, some of them with varying levels of awareness may know that their lives just aren't where they want them to be. And you have to work from where the client's at. And that can be very difficult when you're using a top-down process, because so much of that trauma memory and material is just not accessible in the ways that we're used to dealing with things through speech. When Broca's area in the brain, when the function is dampened, when the blood flow decreases, we can't put words to things. So trauma for many is the unspeakable terror. And trying to pick at that with words almost makes it worse. And so I challenge you all that are watching to think about that when you're sitting across from someone who just does not seem to want to be engaging in a process. We can see it as resistance, we can see it as stubbornness or whatever, but I'm also challenging you to see it as, I wonder what trauma I'm missing here. And that goes into how we address trauma in just a moment, specifically with safety, establishing safety. So some of the other issues in traditional top-down methods is sometimes, especially through exposure methods, we can deepen the connection to trauma versus like leaving the pain and actually helping them to offload that material. And then additionally, not just from a practice level, but macro level, there's a lot of room for growth in the teaching of specific methods to address trauma. And so in counselor education and in research, we're really wanting to push the ball forward. Now, specific challenges, again, this is not saying that these modalities are ineffective. And in fact, a lot of this comes from the application of these things rather than their theory and nature themselves. EMDR is at the top of our list at the Trauma Center, partially because we see so many clients that end up being really, really harmed through the application of EMDR, and it takes them a long time to unweld some of the stuff that happens through that application. And so EMDR requires really, really solid safety and a very good orientation to the present.
I just want to add to that, Shiloe.
Yeah.
With regards to EMDR, in the early research by Shapiro, she was really clear about not utilizing that technique for clients that are dissociative. I see people do that all the time because they don't understand the nature of dissociation or how it presents in the clinical environment. And so that's one of the areas where I see a lot of people who are attempting to do good, but actually doing harm because they don't recognize that EMDR through the trained modality is not necessarily effective for clients that are highly dissociative. Now, under the ego state therapy, we do have techniques that we can blend with EMDR or rapid eye movement specifically that will allow us to process through those. But in the event that you're interested in learning about those are a more advanced technique than what we're going to present today. But we're certainly aware that EMDR has its effectiveness in certain environments, but is not necessarily one of the things that we'd want to do if we have high levels of dissociation.
Yes. And so again, it goes back to that conversation of application. It really, really is so essential, especially when dealing with trauma, that we're very careful in how we apply these things. And not necessarily just being careful in how we apply them, but the part of the workflow, if you will, of trauma, the part of the treatment plan in which they're applied. For instance, the next slide addresses behavioral and cognitive behavioral approaches. It's not, again, that they're bad, it's that out of place and or solely relying on these methods can result in some of these things you see here. The research shows us that behavioral methods specifically have limited effectiveness, and you can have a lot of symptom return over time. And significant risk for abreaction, especially as I mentioned earlier, you have someone that you're just trying to throw words at them when they can't speak about what's going on. They just don't have the capacity because they haven't established the safety, they haven't established the protocols to start working with that material. You might see a lot of frustration or just shut down, or even fear. So some intense risk for, or some risk for intense abreaction. And again, cognitive behavioral therapy, a lot of positives. There's tons of research out there. It's one of the most researched approaches to dealing with lots of things. Now, what we do see is that it gives people skills. Now, one of the bread and butter of CBT is that it gives clients skills after therapy that they can use to kind of self address their issues. One of the problems with that, though, is, again, when you're dealing with something that isn't cognitive by nature completely, in fact, a lot of it's beneath, subconscious, you won't, those skills that you learn, you may notice a degradation or a decay over time in the efficacy of those coping skills. And this is one of the dangers of just relying alone on CBT or other methods and not addressing underlying pain from trauma, is to make it more relatable for all of us. How often have you run into, or rather, I'm sure most of us have run into this idea that someone's telling us something is true and something's wonderful and good, but we just don't feel it. We don't have a felt sense for what they're saying to be true. It almost works the other way for us, and we almost start wanting to push against that idea. And I'm sure some of you have clients that have just sat in that chair across from you and said, I don't want to be here. I don't trust therapists. I don't like you guys. You guys don't help me. And part of that, I can't answer for all of it, but part of that is coming from this idea that they've had all these tools that have been given to them, that have been prescribed to them, and they're just not working. So we have to take another route. And that's when I want to pass it off to Dr. Nixon to talk about the ego state theory.
So going back, and Shiloh has listed for you some of the great resources that you can begin to learn about what ego states are, but just again to simplify it, we're looking at parts of your personality. Early work with this began with Watkins and also Verdern. So those folks started coming after Freud, and of course Jungian psychology also fits into the concept of ego states. As we're looking at how to sort of compartmentalize and identify what this really is, it may be best to describe it as a system of ideas or a mental energies. Freud and Jung both describe them as mental energies or multiplicity. Hildegarde, described it as parts of self, and they talked about this executive part of self, which as you look in our research, you'll find we define that as the higher self. And most of you have probably heard of the idea of an inner child as well as the higher self. And these are really what we're talking about when we're looking at dealing with these subpersonalities. It's the higher self, the inner child, and then those parts that were developed specifically to deal with the developmental stages of life. And so oftentimes we'll see child parts of varying ages. Sometimes we'll have what Shiloh referred to earlier as a weighted ego state. Those are often ego states that have a high level of volatility and may come forward to deal with traumatic instances as they present or as they're triggered from that underlying reactivity. Can we move forward? Another area that you'll look at is Byrne, and Byrne created the dynamic of transactional analysis. And those are another area of research that covered the concept of ego states. He narrowed them down, of course, into the parent, the child, and the adult, which is a simplification. What we found in our work is that there can be more than this in terms of the ego states, and they can be at different ages and stages. Sometimes we'll find ego states that actually compartmentalize certain experiences and may present as the age at which a trauma occurred. So when we're talking about things like very complex traumas that create DID or other types of personality disorders, we would begin to see them in a broader variety other than what you see with just transactional analysis. Again, most of the research will talk about a complex system with an executive. Further describe the executive or the part that you see forward as being ego cathected. So you may hear that or read that in the literature when somebody's talking about ego cathexis. That's the personality that you're dealing with. So as you're watching me here on this screen, you're seeing the part of myself, hopefully, that looks like the educator. I don't act like this in my real life. If I went home and acted like this with my children, they would roll their eyes and be like, "Ugh, can you just get me a sandwich, Mom? Because I really just don't care how smart you are." So I would naturally migrate into the mother part without really having to think about it. And then again, when I come back to teach or to provide therapy, I'm going to have hopefully a higher register of language and present in that sort of ego state, which is the cathected part that's forward. You may also learn about, do you want to move that forward? The internal family systems model, and that's Schwartz. And he gives you a very clear definition of all different kinds of ego states and how they may present. You may have the internal self, or the higher self, which is sort of the executive, the one that's most often seen. You may have managers. They're the ones that sort of compartmentalize and identify tasks and lists, and sometimes they manage other ego states. You may have ones that he defines as the firefighters. Those are going to be the ones that are dealing with high levels of abreaction. And you may have ones that Schwartz identifies as the exiles. Those are the ones that are kind of put out. And oftentimes we find the deepest amount of trauma with the exiles. And when we talk about that in our pain release, I'll give you a few ideas about what that looks like. So Schwartz defined this idea of the ego state family. And we follow up in that, really looking at who is the core self or the higher self, and how do you identify with that, and then who are the parts that are handling whatever is coming forward in that moment. So again, I kind of identify it as the nature-nurture model. The nature part is how we're born and what our temperament is. And the nurture part, that's where the ego states begin to develop, which is how are we developing our rules and identity outside based on our environment. So the concept of multiplicity is seen throughout the literature, and you're welcome to kind of examine that. We have a good reference list at the end of this so that you can review some of the literature that not only went into this presentation, but also into the research that we did on this method. And then I'll turn it over to you, Shiloh.
Yeah, okay. So I wanted to just add to something you had mentioned, which is from an operational standpoint, this transactional analysis, the idea of ego states, what's the usefulness? I wish we had like 4 hours to talk about this and more, because this is just barely scratching the surface. So I wanted to just validate if some of you are feeling like, whoa, what are they talking about? It's a lot of information. This is, you guys are drinking from a fire hose. But one of the central things I find useful about ego state theory and transactional analysis is that when you're dealing with another person and they're acting in a certain way, you can start, if you can start framing your approach to them as, okay, what part of them am I talking to right now? Dr. Nixon was talking about, you know, if she takes this part of herself home, it doesn't interact so well in that milieu. But in a professional sense, this is what is expected. And so when you're dealing with clients, especially if they're stonewalling, they're curled up, they're not wanting to be there, that might be something like, it makes me think the child part, you know, someone that needs safety, someone that needs a little bit different attention, and rather than labels. When we get tempted to call someone, oh, you're just being immature, maybe a more constructive conceptualization of that is maybe their child part is confected, it's stepping forward. So now, bottom-up treatment. This is kind of the getting to the meat of how do we actually use this in our clinic. So I have here a general format for what bottom-up treatment should entail. And we start at the bottom of the pyramid and work our way up. We always want to establish safety, because if you can't establish safety, if you don't feel safe in an environment, you're not going to engage in it. You're constantly going to be in that fight, flight, or freeze state, and we have to calm that. And so, you know, what do we have to do that? Well, mindfulness things that appeal to the senses. We have to do something that grounds the client across from us. You can't sit there and talk to them through a panic attack, nor can you talk to them through a trauma trigger effectively. And so we have to appeal to the senses. We have to calm the vasovagal. We have to calm their heart rate, get their breathing long and slow, those types of things. Once we can establish safety, a sense of stability there, then we can start addressing the senses. And this isn't necessarily linear. You're going to hop back and forth these levels of care on this in this model, because you're going to have to. Nobody's ever going to be in one state like, I'm here, I'm ready to engage in the cognitive today. They're going to be all over the place. And so we have to be fluid on this pyramid. And there may be at varying times throughout your session, times where you have to go back and revisit safety, go back and revisit safety. And so I wanted to note the sides here, the periphery here, reduce pain and skills training. Note that that takes place after safety is established. So both reducing pain and establishing skills. Again, because you can't really do much when someone's in the middle of trying to survive. And
right.
so,
I want to add to that as well, Shiloh. When we're talking about safety, we're talking about mentally, physically, emotionally, and spiritually.
yes.
And because when we're processing trauma work, a lot of it does come out in a physical way. And that comes out whether we're doing rapid eye movement or whether we're doing some of this ego state work. We want to make sure that we're creating safety around that. So techniques may be added at any time to assist in the grounding. But if somebody comes in and they're physically sick, I'm highly unlikely to engage them in a rapid eye movement session, just because it just overwhelms the system. And again, because we're looking at trauma forming differently than traditional mental health issues, we're going to look at how do we resolve them from a physical level. And then when I talk about spirituality, I also want to add that that's an area for cultural competency, because a lot of people show up understanding their spiritual presence very differently. And so we want to be really respectful of how they present in terms of their connections, not only with self and others, but maybe to their environment or maybe to their support group. And so when we're talking about spiritual safety, we're really talking about making sure that there are no active abuse going on, but also that they have a safe support network or ways of connecting and grounding, so that as we move forward, we're not destabilizing them.
And I think it's over to you to discuss the modality that we use, the healing journey, rapid pain release.
So we call this the healing journey, or the rapid pain release. And I just want to differentiate what this means versus sorry, I had to change my slide as well. What this means versus hypnosis. While this is a deep state of relaxation and we use an induction, this is not true hypnosis. It's just sub-threshold to that. We want them to be able to engage in the process in this initial session without feeling like they have any lack of control. And one of the areas that was really present in my research is that hypnotherapy with some of the trauma states or the traumatized parts was very counterproductive for my participants. And they described, the difference that they described that I found interesting was that this method was like going into a relaxed state and having the pain removed, whereas hypnotherapy was like going into surgery, having your guts placed on a table next to you, and then trying to put them back together and go back to work. So I appreciated that differentiation from my participant because as trauma therapists, we want to make sure that we're not moving forward and causing more harm, but rather we're releasing pain. So we differentiated this particular process by calling it process-guided imagery. And in this particular method, we are using a script, and we don't V from the script during the initial sessions. If we are going to V from the script, we're going to do it through a similar induction, but also we're going to do specific ego state work, which again would require additional kinds of training to do. So we've differentiated this, calling it process-guided imagery, and we use a script. So I want to also just talk briefly about the differentiation of what we call evidence-based practice and practice-based evidence. Evidence-based practice has a substantial amount of research, and this particular field using imagery and process-guided imagery is not evidence-based practice as of yet. There are some therapists out there doing ego state therapy. Is still fairly new in the field, especially with regards to trauma. But again, because we're doing the bottom-up processing, I can see this method moving forward very steadily in trauma recovery. So again, this is a scripted method. In the initial phases, we don't go off script. And we're going to just go really quickly through what the script looks like. So the initial part of the script is what we call the induction. And the induction allows you to walk down some stairs, and you either go to a mountain meadow or you go to an ocean. And in this mountain meadow or ocean, that's the initial part of the relaxation. And I want to tell you that if clients are feeling like this is not working for them, because it's sub-threshold to the hypnotic state, they can pull themselves out very easily. And so in order to avoid abreactions, and one of the reasons why we feel like this method would also work with telemedicine is because the abreactions are very, very small when we're using the scripted method. So again, we start with an induction, and the induction walks you down some stairs into a meadow or into onto a beach. And at that point, then we begin what we call the journey, which is walking down a country road. And as we walk down the country road, go to the next slide, we come to a place where we meet with the child. The child is one of the beginning ego states, and what we found in our work is that this ego state will show up at times that were meaningful to the participant, and the goal in meeting with this child ego state is validation and love and taking pain from this child. And so we make the suggestion of take away the pain and exchanging that for love. And then you give the participants the opportunity to either leave the child there or take the child with. And that's a key area that we attend to, because when they don't take the child with, we know there's some other stuff that's probably going on in their life that we're going to need to manage. So generally, if they're in a good place in their life, the child will go with. If they're struggling or they're uncertain about their future, sometimes the child will not go with. The next place we go is the place that we deal with what we call packages of pain. And again, we're using a symbolic language. And the idea of the symbolic language is to ensure that they're moving the things that they're ready to move, and we're not pushing too far. In this part, we have them stack the packages, and then we burn the packages down. And this is one of the areas where we encourage them to not open the packages because, again, we're not doing the deeper processing, we're just moving it. And this is also one of the areas where people have a tendency to say, I really just feel like a lot was lifted and I feel like things just moved. A lot of my clients will describe this as having more space in their brain and just feeling like there's a lighter sense of self. The next place we go is called the place of rocks. And this is a part where I would call this a place of forgiveness, except for that language has a little bit more connotation than some people are willing to accept. And so it's really a place of acceptance, or in some cases, radical acceptance. But it's about giving back the pain that was given to you. And my clients will experience things like throwing the rocks at people, which again is their subconscious, they can do what they choose, or stacking the rocks, or just handing them back. And my clients will often describe this process in terms of the size or the people that have shown up. So we move the rocks, and then we move on to the cabin. In the cabin, this is the place where we actually invite the ego states in. And it's always interesting because if we have strongly baited ego states, or ego states that are carrying too much pain, sometimes they will not enter the cabin. But this is a place where our clients can observe who they are or how they've formulated their experience. And every client sees this differently. In my research, I've found people that identified parts of themselves at different ages. I had a research participant that described his personality parts as panels on a wall. So they really just kind of have their own individual expression of who they are within this cabin. And then our goal in this cabin is, again, to release pain from the states that are carrying pain. In the event that there are parts that do not release pain, those are areas where we're going to move into some cognitive strategies to help them understand, what would be going on, or what their thoughts are about what's going on with those states that are unable to release the pain. And again, they have a very good idea about who they are when they see how these parts show up in the cabin. Following the cabin, we move to the higher self, or the inner advisor. And this is just a place to start to link together what they've experienced on the journey and to start to formulate ideas about how they see themselves in the highest version of themselves. This is often described as a person in white, or an angelic person, or somebody that's very large. I had one participant who was Native who said that her entire tribe showed up. And so again, there's some cultural differences or nuances that are going to show up, and you'll see it most often in the cabin, and then with the higher self, or the inner advisor. The final and closing part is where we move into a theater, and this part is really just giving them some perspective on what they can do or how they can move forward as they're beginning to heal. And so in this part, when they're in the theater, they will sort of formulate a story for themselves about where they're going. And then when I close out this part of the session, we just do a brief summary and talk to them about what happened, what they were experiencing, were there any areas that they're concerned about. And so we do a debriefing following this intervention, and then we'll set up the treatment plan for where we're going next. And again, with some of those ego states that are baited ego state, we may move into some work and assignments on identifying who those ego states are. And that would be the beginning of some of our cognitive strategies, because we're really trying to help them understand who is the sense of who you are, and who is the sense of the parts of you that are struggling, so that we can begin to do that work and make the decisions about whether or not we're going to do rapid eye movement or EMDR sessions, or move into the ego state therapy. Generally, when I'm using this method, like the first 3 years I worked in this field in trauma therapy, I did not V from the script at all. I did not do ego state therapy until I was highly trained in it. So we started with this method scripted, we moved through this method, and then I just would utilize what they saw in the cabin and begin those strategies for helping them to let go of that pain, and then moved back to the scripted method so that they could keep getting rid of those layers.
And Again, just to remind you all, this is a pretty condensed version of everything, and we will come at the end. I'll give you Dr. Nixon's email to contact for specific questions on how the script and things works, what how that all looks in operation, because there's so much material here. It's like drinking from a fire hose. But this is
Yeah,
the general
we're moving
gist.
towards the end where we're going to answer a few questions, but Shiloh,
Yeah.
we have about maybe 8 minutes.
Yeah, and so just really quickly addressing some telehealth alterations. There's in the script. Sometimes we don't achieve full pain release, and because one of the things that we do, a technique we do, is transferring. It's like a transfusion of energy, if you will, using that symbolic language, and we do it by grasping hands with the client with their permission. And we find that that's a pretty key aspect of this pain release. Clients talk about a felt sense of pain leaving them. And since you can't really reach out and do that through telehealth, sometimes the method we have to use is containing it and rather than releasing it, so that the client still has a sense of safety and that they've done some good work. And then finally, script adherence is huge. If in a telehealth setting, we would not recommend any sort of freewheeling or variations. And Dr. Nixon talked a little bit about the practice-based evidence, but as we're winding up here, I'm going to turn it back over to you briefly so you can address these last couple of slides.
I did mention the practice-based evidence versus evidence-based practice, and basically that's just having researched it or having seen this method done. One of the things that we found in the research is that there's different ways of preserving memory, and this method allows you to address the memory at different levels, defining what we call the felt sense of release. And it's a medium through which we experience the fullness of sensation and knowledge about who we are, is what's called autonoetic consciousness. Honestly, that's a whole other training, and so I'm not going to go into that a lot. But what we're looking at is the traumatized memory brought into the present moment, into awareness with the suggestion of release, and that release has a physical aspect to it, which the client describes. And so the physical aspect, if you're open to reading my dissertation, it's described as this pain leaving their body in a physical way. One of my participants described it as a skeletal version of himself emerging out of this muck. So it's a very physical sensation when they have this experience. Shiloh, do you want to talk about limitations?
Mm-hmm. So some of the limitations we've already addressed: highly dissociative clients, and the need to establish safety. Also, we believe that this method is contraindicated for psychosis, those disorders on the schizophrenia spectrum, specifically regarding the ego state aspect, because you don't want to introduce something that is going to make it difficult for someone who's not anchored in reality very stably, and may confuse the concept of parts of self as a literal aspect, and disintegrating. The other things, it's again, since it's practice-based evidence, it's phenomenological. We've gone really deep. This has been in play for a lot of years at the practice, and it's been very, very effective at the practice. But again, we need to we need to go wide. We need to get more case studies done, more quantitative information on efficacy. And then, that will help inform things like the suitability for manualization and knowing how well it works with other diagnoses. And then what are the effects on the overall treatment plan progress. And just wanted to, as we're wrapping up, to open it up for questions briefly. Trauma-informed ego state therapy, specifically the modality that we use, is great because we've noticed it in our practice being very effective, even though trauma can be challenging. this is a very specialized approach that we use. And we also use it in junction. I should note that it's kind of the foundation of the work we do in many ways. We can refer back to the pain release a lot, but it integrates really well with the later stages of the cognitive work. But I wanted to emphasize, if anything to take away from this, is that psychodynamic and psychoanalytic approaches do work very well. And we're excited to see in even research published within the last couple of years, talking about how psychoanalytic and psychodynamic therapies are at least as effective as other approaches in dealing with trauma. So ego state work, as I've talked about, that kind of helps us set the foundation for a larger treatment plan. And I hope that from this presentation, we can encourage all of you to help push the field of traumatology forward, because we need to explore new ways of getting at the trauma to help people heal. And the final thing I wanted to note is that the pain release we talked about, the healing journey, it's not a highly verbal interaction. In fact, the clients don't do a whole lot of responding beyond nodding their head. And so it's a very internal experience they're having. Thank you all again for attending, and we're going to go ahead and open it up for any questions we might have. I know that we had a couple of questions in the chat about the slides, and yes, we will make sure that that information gets to the appropriate places so you can access it. Okay, I'm wondering about access to this. What has your experience been with using ego state therapy with cluster B personality disorder, specifically narcissistic personality disorder? Dr. Nixon, I'll let you take that one away.
Yeah, and I'll tell you what's most interesting to me, and this is one area where I really would like to do additional research. It is effective in allowing them to move forward, but because of the lack of boundaries in cluster B, what we have to do is recreate those ego state boundaries. And so that's part of the modality as well. What I often see in the cabin is so many personalities that they don't know where to put them, or like a lack of awareness about those separations. So we'll see that in their ego state work, that they need to clarify boundaries and create separation. On the opposing side of that with DID, which in this particular type of therapy, I get more DID than most. And with DID, the personality parts are so solidified that we have to work into what we call co-consciousness. We don't do integration, which is a popular technique, although some ego states will integrate on their own. So what we do in DID is to help integrate the clusters into family systems so that they're effective, utilizing the concept of co-consciousness. And with cluster B kind of disorders, what we're going to do is help to create separation and boundaries. And so I really pair this with dialectical behavioral therapy, but the goal again is a lot of restructuring, ego strengthening the ones that need to be managers, so to speak, and hopefully that addresses that. I will tell you that if you're dealing with cluster B clients, it is a trauma-based disorder. So if you're a traumatologist, you're going to see a lot of that. But that would be one where I would start advancing into the ego state work that would be outside of the script and sort of, again, formalizing who they are and individuating, creating that separation both at a subconscious level and in working back and forth quite a bit.
Okay, I'm seeing, do we have any other questions from anybody else that would, oh, let's see, we have
one.
Demographics, yes.
There was one, at what point do you address whether or not the individual chose to take the child with or not without digressing from the script?
Okay, I don't do that while they're under relaxation. I do that after I pull them out of the relaxation and we have a discussion. And I'll just make the suggestion. So tell me what was going on with the child. Any thoughts about why the child didn't go with you? That's just an area that as a therapist, I kind of keep it in my mind, because what I found is there's often other things going on that we need to deal with in terms of safety. So I don't do that while under the relaxation at all. I don't vary from the script. What I do is I just ask them, Does anything stand out for you? Tell me a little bit about this area of the journey or that area of the journey. So really that's more of a didactic discussion and just going back and forth trying to figure out what their perceptions were as we move out of that. And somebody asked me about demographics. I generally don't do this with small children. With small children, I use sand tray because that's a subconscious modality as well. And then we do art therapy. So generally, about 10 years old, I can do at least a modified version of this. We don't have a lot of discussion at that age. We just move through, and almost always when they're young enough after the rocks, they tend to fall asleep. And so then I get them out of the relaxation and we move further. I don't generally get the 10 to 13, I would say, age group is not always as successful about going all the way through. But at about 13, they have enough stability in their ego state system that I can do that work. And so I utilize it with a lot of teens, and teens love this, probably because they don't have to talk to me. So if they're feeling a little resistant, this is a good technique to allow them to just start to feel comfortable and to get some of that internal awareness. So my client population is from 3 to forever, but that age group under 10 and then 10 to 13 are just modified a little bit.
Okay. Again, I think, let's see. Oh, that's procedural question. For the school that I attend is the Chicago School of Professional Psychology. And yes, so I think if that's all the questions, I think that's all the time we have. Thank you everyone for attending again. Look out for the recording of this presentation on the YouTube channel, as well as contact Dr. Nixon at the email listed on this slide. And take care, everyone.
Thanks so much. Have a good day.
And thank you for presenting. I also want to let anyone know who is trying to get CEs that they must complete the CE evaluation by April 19th to get the credit. The link for that evaluation form is on the last page of our program. Hope everyone has a great day.
All right. Hi, guys. My name is Hannah. I'm going to be the room monitor. This is the 1 o'clock Central Time meeting. The host is Erin Moser. It's Stigma Among Mental Health Providers, Identifying Barriers and Advocating for Change. I'm going to give us a couple more minutes because I know other sessions just ended. So I'm going to give a couple more minutes for people to kind of filter in. Let's see. Okay.
Am I able to share my screen from your moderating?
I think so. You should be able to, from what I understand. Let's see.
Hey, David, how did you share your screen this morning when you moderated?
Sorry, I had to unmute myself.
Okay.
There should be a Zoom moderator who comes in.
Yep.
I think it's Elizabeth. Can Elizabeth hear us?
Yep. Oh, here, I should be able to do it now.
Okay, she should designate you as the, yeah, got
You
it?
see my screen now?
Yes, we can see your screen. Real quick before we get started, if everybody but Erin could mute themselves. And then please save any questions for the end of her presentation. So just type them into the chat or save them for afterwards, and then we can get going. So I am now going to start recording. Oh, it's already recording, never mind. All right, Erin, you can take it away.
Okay. So my name is Erin Moser. I am an assistant professor at the University of Northern Colorado. And just to give you a little bit of a background about myself, I have a bachelor and a bachelor degree in psychology and zoology from the University of Wisconsin-Madison. I have a master's degree in rehabilitation psychology from Madison as well, and I have a PhD in rehabilitation psychology. And I'll let you hop in quick and do an introduction as well. Unmute, you gotta unmute yourself.
My name's Amber Perotti, and I have a BA in English Lit, and I'm working on a graduate degree in vocational rehabilitation counseling, and I work with Dr. Moser.
So Amber and I have a lot of conversations about stigma. And so we were kind of talking about what different topics we were interested in. Stigma in media is one we talk a lot about, but mental health stigma, as far as provider stigma, is one we talk a lot about as well. And so we put together this proposal for this conference and wanted to cover mental health provider stigma, but then also wanted to kind of give you this overview of stigma itself and kind of where it comes from, even though that could really be a whole long presentation in and of itself. So I tried to keep it really short and do a really brief overview of that, kind of how stigma is defined, where it comes from, and then transition that into kind of that mental health provider stigma that we see, and then talking about kind of what advocacy is out there and what kind of changes are being made and how we create that change. So the first thing I have here, just thinking about the stigma that's out there now when it in relation to mental illness. These are probably a lot of terms or phrases that you've seen, that you've heard. I know they're things that I've heard either in the media, things that I've heard from other providers, things that people believe that someone with mental illness is dangerous, even that having their illness is their own fault, that they're freeloading either off of the government or off of their family, that their life is rough. So I just kind of wanted to paint that picture that those are a lot of the thoughts that people do have when it comes to mental illness. And so that's kind of where we're at with what they're dealing with on a day-to-day, not only in society and kind of how society treats them, but then also walking into mental health providers and how they're treated from there as well. So this is a table that I wanted you to see. This is actually from Patrick Corrigan. So if you're not familiar with Patrick Corrigan, he is a professor of psychology at the Illinois Institute of Technology. I'm sure you know who he is. He has hundreds of articles on stigma. So essentially, looking at stigma broken down as stereotypes, prejudice, discrimination. These are different constructs that really look at this generic idea of stigma. So if you think about a stereotype, stereotypes are typically these exaggerated beliefs associated with a specific category, okay? So its function is really to justify or rationalize how somebody conducts or relates themselves to this category. So for example, one of the ones that you're probably most familiar with is this stereotype that all Asians are really good at math. Okay, so it's this concept where this idea is framed around this, what people believe is this fact, and then there's this negative evaluative component that goes with it, okay? So it's this prejudice that somebody believes, and then there's this component, this negative component that goes with it. So for example, somebody with mental illness, there's a common belief, as I mentioned earlier, that someone with a mental illness is responsible for their own illness, either because they're not pursuing treatment appropriately, they're not taking their medication, they did something to bring it upon themselves. There's also a lot of belief that a person with mental illness is dangerous, that they're unpredictable. So this essentially results in this fear and this behavior where people are isolating, or they're withdrawing, or they're not interacting with individuals with mental illness because of that fear. And essentially that's perpetuating the stigma and creating more of the problem. And it's doing the opposite of what we're hoping. So we'll talk more about that too, and how we can kind of switch that and help create more contact and not less. So then when you think about prejudice, this would be that aversive or that hostile attitude towards someone, either someone because they belong to a group, simply because they're part of that group. So there's this presumption of them and the qualities that they have because they're part of that group. So the prejudice could be either ascribed to the entire group, or it could be ascribed to that one person because they're part of that group. And then there's the discrimination, which is just the action, that negative action or that behavior toward that person that's carried out based on that prejudice. Okay, so maybe excluding someone that has a psychiatric disability, excluding them from employment or excluding them from housing options because of their mental illness. That would be an example of a form of discrimination. There's another example, say a person with schizophrenia, many times they're stereotyped as being incompetent. So if they're incompetent, then maybe an employer doubts that they'll be able to perform a job. Okay, so that doubt would be the prejudice, so that because they think they're incompetent. And then they avoid hiring them, which would be that action or that behavior. So that would be the discrimination. So this could kind of create this snowball effect where there are other negative behaviors that come from that. So maybe the person ends up hospitalized. Maybe the person ends up with some form of guardianship because they're seen as incompetent. Maybe there's restrictions on their independent living. So all of these things happen because of these perceptions that are created. So then other things that happen like segregation or coercion, these are all different forms of discrimination that occur. Years ago, segregation was much more prevalent. State asylums were more prevalent. Now we still have some institutions, but they're just not as much then, but back then they would essentially, they'd automatically assume that somebody was incompetent, so they would put them in mental institutions. Now, as I said, it's not as much, but there are still limited housing options for people. There is a result of segregation for individuals with mental illness. They end up living in impoverished communities. It essentially forms, at the bottom here, it says these mental health ghettos, that's what they end up referring them to because they're in these impoverished communities. There's also a lot of discrimination in our healthcare system for them, and that's what we're going to talk about a little more. It's a major barrier for them as far as accessible care, as far as their recovery, essentially as far as their overall quality of life. So in thinking about stigma and a definition of stigma, there really isn't one unitary definition. These are just some of the definitions that I found. It's a concept that's prevalent in our society. It's heavily researched. It essentially refers to problems of knowledge or attitudes or behaviors. You can think of it as operating on various levels. It operates on a structural level. It operates on an interpersonal level. It operates on an intrapersonal level. You can think of stigma from a structural level as far as any type of discriminatory or exclusionary policies or laws. You can think of interpersonal levels like prejudicial attitudes and behaviors that maybe increase that social distance. So creating that barrier for people to be included in society, that status loss where people feel like they're not equivalent to others. They feel like they're less than, essentially. And then also that intrapersonal level where people essentially build that self-stigma. So when it comes to self-stigma, the main forms of stigma that are typically researched are public stigma and self-stigma. Self-stigma typically comes from people that hear so much of that public stigma that they end up internalizing it and starting to believe it themselves. And so they then have that self-stigma, and then that all those associated effects that come with it, that their lack of self-efficacy and even increase in mental health issues and lack of pursuing any type of maybe mental health treatment and things like that. So it all kind of perpetuates these problems. So if you think about how all of this is created, you think about our society and how, you know, our society looks at people, and we kind of have this innate tendency to notice differences, and even in animals, this natural reaction to notice differences and to function in a way where you're always looking to keep things safe. You always want to make sure that there is nothing that's going to create any chaos. So it's really not surprising that when groups notice any type of difference, they respond in a certain way, more vigorously or not as vigorously, if they perceive anything as a threat. So most times when there's differences, people ignore them. They're irrelevant, they're not a big deal. There are some characteristics, typically like age, gender, skin color. Those are considered like these natural characteristics. So they're categorized as differences, and it's not a big deal. Other things, when stigmatization occurs, there has to be some type of difference that's linked with like an undesirable trait. So that will create that, that underlying change or that stigma. So with mental illness, there's this association of illness with these stereotypes of potential violence, of communication problems, of unpredictability. And those come from a lot of different places. There's a lot of history of where negative attitudes and beliefs come from. I took a course in undergrad on media and mental illness, and it's always kind of stuck with me. And I even to this day see and think about that when I watch different things and how mental illness is portrayed in the media. One of the big things that my professor would do, she would show a lot of Law and Order, and pretty much every episode of Law and Order back then, they would have the person who committed the crime was typically homeless. They were typically unmedicated. They were having some form of a psychotic break. They were dangerous. They were violent. They were unpredictable. And it was routinely over and over again, every episode, that's who it was that ended up being the person that they found. And so that kind of contributed to our society thinking that this is what mental illness is like, and this is how people react. This is how people are if they have a mental illness. And so what it does is it kind of creates this separation of us versus them. So now we have this category of us where we are the people that kind of have that higher status, and we don't have the mental illness, and then it's the them who have a lower status than us, and they have a mental illness. And that's where that stigma comes from. That's where that group is divided. That's where people view them as having this lack of power, this decrease in their social status. So with that, personality disorders are one of the mental illnesses that is highly stigmatized, especially in mental health providers. For some reason, there's this belief that personality disorders should be able to control their illness, that their symptoms are really more just manipulations, and that they're really just rejecting the help that they're being offered. They're seen as just being more difficult, and that they're really just misbehaving rather than actually having an illness or being sick. So then there's this lack of sympathy for them, and they just feel that people need to reach out and get professional help, and if they don't, then that's on them, and there's nothing that they can do. So really, an individual with, say, borderline personality disorder. These are probably the most stigmatized of all personality disorders. Individuals with borderline personality disorder can be characterized with moods, their instability. They have extreme sensitivity to abandonment, or they're very impulsive. They may self-mutilate and have difficulty controlling their anger. They have severe limitations in social relationships and functioning. So oftentimes they're seen as annoying or undeserving, and a lot of the time this results in inadequate treatment and help. They have frequent contact with law enforcement because of these outbursts and these anger and control issues, and suicidality is frequent as well. And this in turn leads a lot of law enforcement to be very frustrated and angry and powerless over their interactions with individuals with bipolar disorder. And so that again kind of perpetuates that stigma and how people are reacting to people with mental illness, and especially personality disorders. And so looking at mental health providers specifically, you would think that because we go into the field to help people, it would be kind of innate in us to do what we can to help everyone that we're working with. But despite that, most studies have found that not only do mental health providers express stigma toward mental illness, they actually, if not have similar beliefs, but they actually may have higher. They may express higher stigma than the general public. Even decades ago, the U.S. Surgeon General asserted that stigma surrounding mental illness is the most pressing issue for our mental health field. So this really looked at how it affected individuals entering treatment, how it affected them adhering to treatment, because once they came in, they didn't find that they were receiving the services that they wanted, or that they weren't even helping. And then terminating that treatment early because it wasn't doing what they felt that it should. So if you think about that public stigma and then look again at what we call provider stigma, the provider stigma is this negative attitude, belief, and behavior that they possess, and then they enact that toward their clients, whether it's something that they do unknowingly or even subtly. This would be where that provider stigma comes from. So that could be any mental health professional. It could be a person's psychiatrist, it could be their psychologist, social workers, counselors, psychiatric nurses. It could be paraprofessionals such as mental health technicians, really anybody working in the mental health field. They could have dislike, anger, neglect as far as what type of treatment they're providing. There have been studies that show many psychologists and clinicians rate people with schizophrenia or borderline personality traits as undesirable as far as working with them. They want social distance from them. When I was working at the VA, I remember specifically having people tell me that they didn't want to work with anyone with an access to or personality disorder. I would have people that would specifically try and get them off of their caseload because they couldn't be cured, or because there was no medication for them to take. So it was interesting how people would talk about clients that they had and how they treated them. And that's one of the things that Amber and I are going to talk about, is just how that comes across. Because if you think about our ethical codes and doing no harm and treating everyone equally, that's not coming into play with how they treat individuals with mental illnesses, if even, as I mentioned, if it's subtle or if they're unknowingly doing it because of how they feel towards someone with mental illness or towards someone with a personality disorder more specifically. So there are these barriers to care. So it's hard if someone is already feeling that they're stigmatized in society. It's hard for them to come in for services. But then once they come in, if they're confronted with that label, it's even harder for them to continue those services, especially if it's something that happens right away, when it's one of the first treatment providers that they see. That can really set the stage for more difficult treatment for them. It could be that they never come back for treatment. So maybe they stop taking any medications. Maybe that goes across the board for any type of treatment that they go to, any type of doctor that they see. It can really have this ripple effect as far as any of their treatment. It reduces the quality of services that they're receiving. It, you know, they'll have this feeling of, you know, why would I go see this treatment provider if they're going to treat me like this? Even for people with borderline personality disorder, they have this feeling of exclusion, especially if someone maybe diagnoses them and then refers them out because they don't have them on their caseload. Maybe they put them on somebody else's caseload. Suicide attempts among individuals with borderline personality disorder are high, and a lot of the time they're viewed as attention seeking rather than it being a sign of illness, which, if you think about it, would be incredibly difficult to be working with someone and have them not believe that you're truly in need of help. It's a concern because people may be overdiagnosed, so they may be negatively labeled, which can lead to a lot of other problems, more negative prognoses for them, more limited treatment choices for them. A lot of their problems with treatment could be that they're marginalized. So they're treated as they're insignificant. They have less adequate treatment. Sometimes too, the focus is so much on their mental health that their medical treatment gets kind of put to the wayside and it's not focused on as much. There was a study conducted in 2013 that really focused on the consumers and their families and what they felt they were receiving from their providers. And they kind of came up with these different themes that each of them felt. And a lot of what they felt was this blame and this shame from their providers. So basically, they felt that they were being blamed for their difficulties. They were blamed for their illness. They were blamed for progressing less than what they felt than what their provider felt that they should be, feeling shame that they were less than what they should be compared to what other people in society were. They felt like their provider was disinterested, like they were annoyed with them. So any of their concerns that they had or concerns that their family members had that they brought up, they felt like their provider just wasn't interested in what they were doing and what they were saying and wasn't really trying to help them with them. They felt like any type of information they asked for or any type of requests for services that they had, that the provider was annoyed or irritated with them for asking those things. They felt very degraded, that they were in this lower social status than the person that they were working with. They felt very dehumanized. It made them feel like they were going to have a very poor prognosis, which, again, think about how that would feel if you're trying to get help to better your quality of life. And all you feel when you're working with somebody is that you're not going to not only get better, but you're not going to obtain any of the goals that you really have, as big or small as they are. And they also kind of created this dependence. So it fostered this dependence on either the person they're working with or just mental health services in general, support services, medication, which, you know, a person with a mental illness probably will have services, but to have services in a way that's a positive, not necessarily this thought of being dependent on it. And then also they felt like they lacked these real choices. So we really focus on a client-centered approach and helping the clients come up with things that are best for them and what they want. But in this regard, they felt like all those real choices were taken away from them. They felt like essentially the providers were using their power to force certain choices on them, whether or not that meant hospitalization, whether or not that meant supported housing versus independent living. For me, it would be some type of employment, whether or not they wouldn't let them work, things like that. So these provider attitudes have a lot of influence on their outcome measures, on how they end up doing as far as their quality of life, their life goals, anything that they can do, and even their adherence to any of their treatment plans. Most likely affecting anything and everything in their life. So over time, the person's going to internalize all of these negative attitudes. They'll avoid seeking treatment. They will essentially internalize it and maybe start judging other people more harshly. Mental illness is judged a lot more harshly than physical illnesses. It makes people reluctant to seek treatment because there's this bias toward it. And then again, it affects the healthcare system because people aren't providing that care in this universal, or what word did I use? I guess blanket way toward everyone. So it's not this same standard of care as far as mental health goes and providing that care to everybody. So I'm going to transition to Amber. Amber, you got to unmute though.
Okay. So researchers Gronholm and Henderson named stigma amongst mental health professionals a wicked problem. I'll get into that a little bit more later, but going off of what Dr. Moser just said, I think that's a pretty good way to describe it. Their conception of a wicked problem is not only a problem that's difficult to tame, but also one that clearly has some pretty major implications for patients. Obviously, it's not what a patient expects when they come in the office. They don't expect to be faced with stigma. They're asking for help. So that leads us to the question, what do we do about this wicked problem? Two interventions that are brought up pretty frequently and that were talked about by Corrigan especially are education interventions and contact-based interventions. So I'll start with some of the education-based interventions. In 2011, there were 16 population studies that were done over the period of time from 1990 to 2006. They were investigating education initiatives on depression and schizophrenia as biologically based illnesses. The studies did show that education interventions did actually teach that schizophrenia and depression were biologically based illnesses. The surprising result of this, however, was that there was no change in stigma about depression, and they found that stigma was actually worse for people with schizophrenia. So this was a little bit bewildering because they were hoping that education would help, and it seemed to have hurt. It seems that a couple other researchers have looked into education interventions, and they've seen that they actually increase the desire for social distance from individuals with mental illness. And they're actually associated with beliefs that people with mental illnesses are dangerous and incompetent. This could be due to the fact that a lot of these illnesses are looked at as biological and thus hardwired, which tends to lead to the stereotype that someone with a mental illness will never recover. And that's something we'll talk about in a lot of interventions, the lack of focus on recovery, something that is very important. Next slide, please. Dr. Moser, oh, thank you. Okay, so what can we do to improve education interventions? So a couple of researchers have indicated that that these interventions shouldn't focus primarily on a biological origin for illnesses, but actually teach a more biopsychosocial approach by not focusing entirely on that hardwired view of mental illness, they can look at various aspects of a mental illness, including the fact that mental illness can be looked at as a continuum versus a strictly defined biological diagnosis. This helps in the sense that some aspects of mental illness can be looked at as a human experience that is experienced by more than one person or more than one diagnosed group, and therefore less stigmatizing and isolating. Another very important, and actually one of the more successful interventions, are contact-based interventions. Research has repeatedly shown that contact between people with lived experience of mental illness, sharing their stories, and counselors helps to decrease stigma. This is also true of people who have mental illness interacting with the public in general. The interventions that focus on contact are shown to diminish anxiety, heighten empathy, make personal connections, and improve understanding between clients and counselors. Next slide, please. So one of the questions that inevitably comes up is, counselors have contact every day with clients. So if that is the case, then why do we continue to see counselors stigmatizing clients? One of the theories is that counselors repeatedly see patients at their very worst or at their most unwell, and they begin to assume the worst outcomes for patients in general. Recovery is often left out of the entire process and out of the discussion. This belief can also lead to the person, the client, feeling that internalized stigma, maybe even believing that they can't recover themselves. Another theory involves the fact that the therapeutic alliance may actually be unequal in its very nature. It may not actually have the 4 criteria that Allport put out about reducing prejudice. He felt that equal status, common goals, cooperation, and institutional support were all key factors in having an equal alliance. And if those don't exist, then it creates basically an environment where there is the labeled and the labeler. And so really focusing on an even alliance between both the client and the counselor would help reduce that prejudice, or even the inclination towards that prejudice. Next slide, please. Okay, so one of the most successful interventions is the Opening Minds Anti-Stigma Initiative study. And there's been a couple of evaluative studies of this particular anti-stigma initiative. And one in particular did actually look at the most successful factors of this initiative study. And I think we could probably look at these factors and apply them both to personal counseling sessions and also to how we train future counselors. These are the key elements that were identified in the study. First and foremost, anti-stigma intervention should have an emphasis on recovery. Again, as we discussed before, there's a pretty prevalent view, both from education and initiatives, and even, as Dr. Moser pointed out, perpetuated by the media, that mental illnesses are hardwired, that people don't recover from them, that they're dangerous and incompetent. And I think a particularly dangerous element of that is the fact that someone could never recover. It's difficult to find work or rent an apartment when there's a perpetuating belief that you're never going to recover from an illness that you have. The second is to teach counselors skills involving what to say and what to do in the face of stigma. This is important because it was shown that there was a lack of communication skills between counselors and clients, even kind of an underlying fear of clients and feeling that open communication could lead to bad outcomes. And this kind of stigma can block any kind of communication between counselor and client and lead to bad outcomes. Additionally, anti-stigma initiatives should employ myth busting. That's one of Dr. Moser likes to do myth busting in class a lot. She's constantly kind of talking about, well, this is what the public believes about, say, depression, and this is the reality. And it is important that we continue to point those out on a regular basis. Also, it's very important to have an enthusiastic facilitator who models a person-centered approach. Also have a trained speaker who has lived experience of mental illness. Again, people who have a lived experience of mental illness are key in this process. We can't really discuss stigma if we don't discuss the actual experience of people with mental illness. Contact with those individuals on a regular basis will help to sort of break those stereotypes and views that unfortunately are so prevalent and continue to be perpetuated. So it's true that we do have a lot of experience with people with mental illness as practitioners. So the important key part of this is to make sure that we not only listen to people with experiences of mental illness, but we seek out people who have a recovery experience and that we give them a voice. As they point out here, in these initiatives that have worked, like the Opening Minds Anti-Stigma Initiative, they employed multiple forms of social contact with individuals with that lived experience with mental illness. They had multiple live speakers. They had presentation from video featuring speakers, and they had multiple points of social contact between program participants and speakers. They would not only have a speech, but they would sit together and have lunch. So it created a nice conversation about what people with mental illnesses experience, and most importantly, how they recover or how they even look at their own recovery process. Something that unfortunately educational initiatives and maybe even professionals themselves haven't been highlighting. And if you can't highlight recovery, I'm pretty sure you can't find it. Next slide, please. Okay, one of the arguments that comes up for counselors when they're faced with an anti-stigma intervention is that, hey, you're talking to the converted. I've already learned all of this. I'm compassionate with my clients. I definitely understand what they're going through. I think it's very important that we kind of look at the model of the Opening Minds Anti-Stigma Initiative. They made sure that they discussed the process of how to give actionable strategies to these kinds of counselors. The ones that feel like, I already know the story. Well, let's give them somewhere to tell the story. Let's give them somewhere to put it into action. So policy change work is one of those options. Another is quality improvement of anti-stigma practices and interventions. Most of the studies that I looked at today were studies of studies and meta-analysis about anti-stigma interventions and what could be done better. So we can only continue to do that and do it on different perspectives and different levels and focusing on different approaches. Also, one of the key items, obviously, as I mentioned before, is that clients need to be supported in telling their story. That means if you have clients who are having a successful recovery, get them out there, have them talk in an anti-stigma initiative, have them discuss their experience. And talk about what works for them, because that's such a key part and something that's really missing and leading to stigma of clients in general. Next slide, please. Okay, so one of the things I wanted to talk about, I started this presentation talking about the wicked problem. And that is something that I think is very important. Not only did we just discuss that counselors do need to continue, they need to, push into policy change, quality improvement of anti-stigma practices, and also support clients. But in addition to that, I think it's really important that we remember what Henderson and Grolnome were talking about, that this is a very wicked problem. Let me tell you, design theorists actually came up with the concept of a wicked problem. And they introduced the term to draw attention to the complexities and challenges of addressing planning and social policy problems. They referred to tame problems, like those in mathematics and chess, as those were the tame problems. The wicked problems, they lacked clarity in both their aims and their solutions. So basically what they're saying is this is not an easy problem to address. In addition to the challenges of articulation and logic, they're subject to real-world constraints, and they prevent multiple and risk-free attempts at solving. So a wicked problem is not something that you can approach one time and solve it. You have to continue to come back to it, keep evaluating approaches and solutions, making sure that something works, it doesn't work, it continues to work. And that's something I think we need to remember with stigma, is that it's an ever-changing problem that we need to continue to keep addressing, both in internal sessions with clients and in policy, and also in anti-stigma interventions. Thank you.
Sorry, I had to unmute. Thanks, Amber.
Thank you.
Does anybody have any questions?
Oh, I have a question. There we go.
Yeah, hi.
Hi. So I started out as a peer support counselor, and now I'm a therapist. So my workplace is very aware that I have mental illnesses, including some of the more scary ones that attract stigma. And so one thing that I've been finding a lot is that when I try to advocate for my clients, I get the, well, obviously you're going to say that because you have it too, kind of dismissal.
So your question is how to get around that?
Yeah. Since I'm new to the workplace, so,
Sure.
And I'm younger than most of them.
So what is it you're advocating? Is it you're advocating for certain treatments for them with your peers?
Yeah, it's advocating for certain treatments, or just like, hey, don't say a sweeping they generalization about our clients.
Educating.
Trying to, yeah.
Yeah. So what specifically is your question, I guess?
Sorry.
How to
I guess it's, what have you guys found what have you found to be helpful with the things where, because obviously people in the mental health industry have mental illnesses too, you know, it's not a rare thing. So have you guys found difficulty in tackling that before?
Yeah, I actually, what was interesting, some of the research that I was reading talked about how therapists with mental illness actually don't disclose as much because they don't want to be labeled as their consumers. And so there's actually less treatment providers that disclose that they have mental illness. You are doing what I would suggest, so educating people and just saying, you know, you can't use blanket statements like that, and just essentially calling them out on what they're saying. As far as specifically how to advocate, like Amber was saying, it's kind of, and as I mentioned before, all those different levels. I always think about it from kind of that base, that if we can start kind of at the ground level and work our way up. So you're doing it in that regard, where you're talking to the people that you're working with, and just for the fact that you're doing the job yourself and you're working with your clients, that is a key component of it. And then, as Amber mentioned, any of your clients, having them use their voice for any way to get that anti-stigma campaign out there. Amber, do you have any other suggestions?
I think a personal suggestion would be, you know, tell your client you're advocating for them. Because I think that's one of the complexities is maybe people aren't seeing that they might even have a voice from another place. And that is quite meaningful. I think that might be, they may be able, if they can't find a voice of their own, they may see someone advocating for them, and that's a good start.
Okay.
So I'm really glad you do that. That is, you're doing what this presentation is asking.
Okay. All right. Thank you. I wanted to make sure I wasn't like missing.
No,
Oh, no. Any other questions?
All right. If nobody else has any questions, if you could just please fill out that survey. I will send the link again. This is how we're going to be taking attendance. And I know some of you private messaged me and said that your other room moderators didn't take attendance. I was told to, so that's what I'm doing. So if you guys just want to fill out that survey, that's how you're going to get points for this as well. And yeah, thanks for coming.
Thank you, everybody.
Thank you.